Good evening, everyone, and welcome to Wednesday Wellness, a free live educational series brought to you by Trinity Health. We are thrilled to have you with us as we dive into the important topic of breaking the headache cycle, innovative treatments, and self-care tips. Before we get started, here are a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A feature located near the bottom of your screen, and our presenter will address these questions at the end of the session. Lastly, today's webinar is being recorded and a link to the video will be sent to you early next week. Without further ado, it is my pleasure to introduce neurologist Dr. Audrey Sanders.
Thank you so much, Brittany. Hi, I'm Dr. Sanders. Just a little bit about me, because that always kind of helps break the ice a little bit. I am born and raised in Grand Rapids, Michigan, so I'm very happy to be working at Trinity Health back in my hometown, treating neurological conditions in my community. It's been a great honor working for Trinity the past 6 years. The other thing that also I'm very passionate about headaches is not only because it makes up a predominance of my practice is because I'm also a chronic migraine sufferer. So a lot of the things that I'm going to present today, I also try to adapt in my own life. And I have walked in the shoes of probably many of you or your family members that are struggling with headaches. And it's not an easy cycle, but it's something that can be broken. And I hope I can share some very helpful information for you to listen and help adapt in your own lives or those that are affected by headaches in your life. So we'll go over kind of our overview here. So during the talk, I'm mostly going to focus on migraine, but there's a couple other primary headache forms that I will touch on as well. And in the questions, I would be more than happy to answer any other questions about other less frequent or less common headache types if those questions arise. We'll also go over the common triggers for headaches, and more importantly, how can we limit or counteract them. We'll also touch on a very important topic called medication overuse headache, which is a very common contributor to chronic headaches. And then we will dive into some of the rescue therapies, preventative therapies for migraine and the other headache forms. We'll also touch on nutraceuticals, meaning like supplements that have some data to help predominantly in migraine. And then we'll also talk about kind of a more exciting treatment option that's been coming out in the last few years, something called neuromodulation devices. So primary headaches, the way we define that is a headache that arises on its own and it's not caused by anything else. So this would be something that's not caused by something concerning like a brain tumor, for instance. Obviously, that's something that we as neurologists, headache specialists, or primary care physicians have to think about when someone's coming in with a headache is there another underlying cause? But the focus of today's talk is going to be primary headaches. So we're going to talk about migraine, tension type headaches, and cluster headaches. So migraine. Migraine is a very important topic because it affects so many people in this country. It affects over 37 million Americans, which translates into about 15% of the general population. The World Health Organization places migraine in the top 10 most disabling medical illnesses that people can encounter or experience. And those that have suffered with migraine can certainly attest to that. It definitely is a more female predominant condition, although males can certainly be affected, and we'll kind of touch on why that may be. The thing that can be very frustrating about migraine is it tends to peak around people's most kind of productive years, in your 30s. So people are raising families and in the workforce. And so these can be very disabling headaches that can limit how, people can interact with those in their family and be able to be productive and go to work and school. During that decade, it can affect around almost a quarter of females, and then males about 7%, and that's the highest prevalence peak. The other thing that's kind of striking is how much people go either undiagnosed or untreated. So there's a statistic that was in a consensus article that I looked at that said only about a third of migraine sufferers seek medical care. And of that 1/3, only half of the patients get the right diagnosis. So migraines certainly can be underdiagnosed. So how do we diagnose migraine? So in my world, something that we look at very commonly is something called the International Classification of Headache Disorders, which basically has all the headache disorders out there and what a patient has to have in order to meet a certain criteria. So this is where it gets a little bit more medically based, but it's important because, to be able to recognize when you might be having a migraine or somebody else. So someone has to have at least 5 attacks. I mean, certainly we still treat people even if they've had their first couple of attacks, but in order to truly say this is migraine, it's something that's recurring. The headaches typically last 4 to 72 hours, and that means untreated or undertreated. So certainly we want someone to get better sooner with rescue medications, but if someone were to not be on the right medication, or they were going to, or maybe they don't have treatment yet because they're undiagnosed, the headache typically lasts 4 to 72 hours. Patients will have to have at least two of the following 4 characteristics, okay? One-sided location, of pulsating quality, moderate or severe pain intensity, and aggravation by or wanting to avoid even routine things such as walking up and down stairs, bending forward, things that we just kind of do in our daily activities or daily life that can certainly worsen a migraine. And so as you can see, only two of those 4 characteristics. So sometimes patients will come into my office and say, well, I can't have a migraine because it's both sides of my head. And a lot of times I think in the past, it was kind of thought that migraine was typically just a one-sided headache. But as you can see, you only have to have two of those 4 characteristics. So you could certainly have a both-sided headache and still qualify. The other thing that we have to know is kind of the associated features that come with this headache. So you have to have at least one of the other following: nausea and or vomiting, or light and sound sensitivity together, or certainly you could have both of those. That's what really defines migraine. There's lots of different migraine subtypes. So the most common that affects about 70 to 75% of migraine sufferers are those that have a headache with its associated symptoms, but they don't have a warning beforehand, which is called an aura. Um, in contrast to that, about 25 to 30% of migraine sufferers do have an aura. And that most common aura is a visual aura, which can be described in lots of different ways. I did put a couple pictures I found online that are kind of very characteristic auras that people will describe, like seeing colorful kaleidoscopes or seeing kind of zigzag lines that maybe start in like the peripheral vision and kind of carry across their visual field. Or it can be blurring of vision. So lots of different ways that that's described. But aura can also be more than just visual. It can be sensory. Some people will have maybe numbness and tingling on one side of the body, or their face will get numb. Or they can have language issues where they start losing track of their words or slurring their words. So it can present in different ways, but visual aura is the most common. And then there's something called retinal migraine, or ocular migraine is another name it goes by. And these are very brief compared to like the 4 to 72 hour headaches that we have for a classic migraine. These are usually about 20 to 30 minutes in duration, and that's just the visual symptoms alone. Although occasionally patients might complain of like a dull headache, but that's not the most striking symptom. They are more concerned about the visual symptoms. So that's something that can happen as well. Another subtype of migraine is vestibular migraine. This one I think is very underdiagnosed, and vertigo in general can be very tricky to tease out. So this is a migraine that has vestibular symptoms, that meaning like vertigo, like some sort of illusion of movement, which people will say maybe they feel like they're spinning or the world is spinning or they're rocking or some sort of motion is happening, a sensation of motion, I should say, rather, that's not really truly happening. And those symptoms can be very brief. They can be like 5 minutes, but they can last up to 3 days. And the thing that can be tough about teasing out this type of migraine is that you don't always have to have a headache with this type of migraine. To meet the criteria, at least half of your episodes have to have a migraine type headache, but that leaves up to almost half of them that don't. So it can be sometimes difficult when someone's coming in saying, why am I having these dizzy episodes? So it really takes kind of a ability to take a comprehensive history to determine that. And then there's a couple other rare subtypes of migraine. Another one's with brainstem aura. So this is something that someone might present with confusion and slurred speech and double vision. Pretty rare. I maybe have 1 or 2 patients in my practice with this. And then something even more rare than this is something called hemiplegic migraine that tends to run in families, and it's genetic. This is where someone truly has dense weakness on one side of the body in the setting of a migraine. So those are the subtypes of migraine to keep in mind. So we also can define migraine based on the frequency of the headaches. So episodic migraine is meaning that someone has migraines 1 to 14 days a month, so less than half the month. And then in contrast to that, chronic migraine is 15 or more headache days a month, but only 8 of those have to qualify as migraines. So you could still have another type of headache, like tension type headache, or something called cervicogenic headache, and still meet criteria as long as you're having 8 migraines a month. And that frequency has to be present for 3 or more months to meet that criteria. So moving into kind of why people get migraines, that's a very common question I am posed with when people come into the office. And that's a great question because we don't know everything about why someone gets a migraine. But what we think so far is that it's a complex interaction between someone's DNA, so definitely can run in families, be hereditary, as well as environmental factors. And the thought in patients that are predisposed to migraine is that they may have something dysfunctional in a part of the brain called the hypothalamus. And the hypothalamus is kind of our regulatory center. It does a lot of things that are important. It regulates our sleep wake cycle. It also governs cues for hunger and when we're satiated by food. It regulates a lot of the hormones that are secreted to do other functions in our body. It also has direct nerve pathways to receptors in the eyes and the nose, which is kind of interesting in terms of when we get into triggers for migraine. And also it is involved in something called the autonomic nervous system, or how we learn in medical school, autonomic meaning automatic, meaning the things that our nervous system just does for us that we take for granted, like digestion and respiratory and circulatory things. So we'll kind of get into that as why we think the hypothalamus is so important in migraine. How is pain generated? This is a pretty complex system of things that happen. So what we think happens based on what has been shown in research is that messengers in the brain, such as serotonin, which is one of our neurotransmitters, it's also like a feel-good chemical, but does a lot of other things in the body. It spreads the migraine mechanism through the brain to a part of the brain called the brainstem. And then the signals there, then they signal another nerve called the trigeminal nerve and some other nerves in our neck that then respond by having blood vessels dilate around the head, face, and neck. And then the impulses further travel down nerves to release additional chemicals that then cause further blood vessel swelling and inflammation, especially on the scalp around there. And then those blood vessels stimulate pain receptors on nerve endings that then send signals back to your brain to say, I'm in pain. So that's how we think pain is generated. So certainly we know that headache or migraine is a headache. People have pain in their head, but we also know migraine is much more than a headache. And anybody that has a migraine knows that it's more than just pain in the head. That's what can be so frustrating about people that don't understand what a migraine is they think, well, you should be able to go to work. It's just a headache. But there's a lot of other things that are happening because of different things going on in the brain and the body. So again, the hypothalamus, that regulatory center in the brain, is thought to be responsible for some of the other symptoms that we get, like nausea, vomiting. People can have diarrhea. They can actually have increased urinary frequency kind of leading up to a migraine. They might get flushed in the face, or they can even be pale, and you can have chills, and sometimes even people report feeling feverish. The blood vessel inflammation that happens in the coverings of the brain, which are what the meninges are, those are thought to be responsible for the light and sound sensitivity and the neck stiffness that people can experience. A lot of times people will think they have a neck problem, that's what's causing their headaches, but it's really part of the migraine because there are these nerves in the neck that are activated because of the blood vessel inflammation. And so neck stiffness sometimes can be a heralding symptom of a migraine coming on. There's electrical disturbances that happen in the brain, and this is thought to then cause some constriction of blood vessels. So before we dilated them, and now these other substances are going to cause constriction of the blood vessels, and this can be why we think some people get aura, and that can be like the visual symptoms, the speech disturbance, the numbness and tingling, and the dizziness that people might experience. So another really important concept to understand is something known as like a trigger level versus threshold. This is explained in a lot of different books that someone might look at about migraine. And a good one that I'll also tell you about too, because it's in my sources slide, is a book by Dr. David Buchholz, and he is a neurologist out of Johns Hopkins that wrote a book called Heal Your Headache, and it's very good. And he goes into this in very great detail. So the thought about why some people get migraines and other people don't is that they have different varying trigger levels. And trigger levels are the factors that can cause a migraine to start. And that can vary from individual to individual. And we're going to touch on those triggers quite a bit in the next few slides. And then additionally, there's something called a threshold. So this is the level at which these triggers will activate a migraine in someone. And this again can vary from individual to individual. So the thought is that some people, based on their genes and other factors, have a lower threshold. And that's why some people may have migraines very frequently, whereas other people have a very high threshold, and maybe they never get a migraine unless maybe when they're sick. And that's what's the thought to be the difference between people. So as the total trigger level rises above the threshold, so different things that are happening in someone's life, the migraine mechanism is activated, and that's what causes the migraine. And sometimes this can result in symptoms for more than just a day. If someone's having lots and lots of triggers and their threshold is activated, they could sometimes have symptoms for weeks, months, or sadly for years. And so the goal is to try to raise that threshold by reducing the triggers. And here's a schematic that kind of goes over that. So in this example, you can see kind of in the lower left side, this buildup of triggers, right? So this, female may be on her menstrual cycle, and then she's having a very stressful week at work. Maybe she had to work late one night or up late to do a presentation for a deadline, and she had to miss some meals, and then bam, you hit that migraine threshold, the attack is triggered. And so then on the right-hand side, the goal is that by modifying your lifestyle and medications, could we help lower that threshold? And then obviously something that we can't control is our genetic factors. That's something that might predispose people to have a lower migraine threshold than others. So in Dr. Buchholz's book, he has a really great quote, and this is kind of the nuts and bolts of my philosophy for treating headaches, is the key to controlling migraines and headache symptoms is to keep your trigger level below your threshold. And that's the goal for all of us. So let's go into some of these factors that can contribute and cause migraine. So the main kind of categories for this are lifestyle factors, and then there's also some medical factors. And then something that doesn't really fall into either of these, but many people struggle with, is weather and barometric pressure changes. So for lifestyle factors, this includes things that we can at times regulate: our sleep cycle and sleep amount. Exercise, that can be something that sometimes can be a trigger for headaches, but then lack of exercise also has a lot of data to suggest that can trigger migraines. Our diet, our hydration status, caffeine, which we'll talk about how that can be a double-edged sword with migraine, stress, and then things that we're exposed to in our environment, such as bright lights, sunlight. Strobe lights can be very triggering for people, certain strong odors, loud sounds. So sometimes we can control these things, right? Medical factors also can contribute. So we'll talk again, like I mentioned in the overview slide, about acute medication use or medication overuse headache and how that can contribute to headaches and kind of fuel the fire. We'll talk about hormonal or menstrual cycle as being a big component of some women's migraines. We also know that people that have other chronic pain disorders are predisposed and more likely to have migraine. Same thing with psychiatric conditions and history of abuse. We'll touch a little bit about that as well and why that might be. And then kind of in line with sleep, obstructive sleep apnea, a medical condition, can also predispose someone to migraine. And then hypersensitive nerves. And then we'll certainly touch on weather, because that's a big one. Some of you may be struggling with your headaches because of this weather storm that we're having right now with all the wind and the cold air. So migraine and sleep. Certainly the thing that can be very frustrating for migraine sufferers is they do best when things are very regulated, and that's just not life, right? People have families, they have jobs, they want to do things, socially that might change their sleep cycle here and there. The thing that also can be frustrating is some people can get a migraine from oversleeping. So on the weekends, when you're tired and you've been working all week, and then you want to sleep in or take a nap because that's, just kind of our right, when we're enjoying ourselves on the weekends, that sometimes can trigger a headache. So it's really important for migraine sufferers to try their best to keep a consistent bedtime, which is a lot easier said than done. But strict bedtimes and wake times, even on the weekends, can help prevent some of those headaches that happen on the weekend when we least want to have a headache because we want to enjoy life. You can regulate your bedtime routine. That can be helpful too, just to help kind of wind down. People a lot of times will say if they struggle with insomnia. So sleep hygiene can be helpful. Addressing potential sleep issues, either with your primary care doctor or if there's concerns for teeth grinding with your dentist to get maybe a bite guard. We'll talk about sleep apnea on the next slide. And then just making it a priority. This is something that can be very helpful for migraine sufferers to try to lessen their risk of getting a migraine. So migraine and sleep apnea, this is something that we often think of if a patient is coming in and saying, I'm having headaches that I awaken with every morning, or they're awakening me out of sleep. And then we might screen for other things like how is your energy level during the day? And if they have a bed partner, do you snore at night? Do they ever hear you stop breathing? So those are things that are important to discern. Some studies have suggested that almost 10% of patients with sleep apnea may have migraine. And the thought is that it may be due to low oxygen levels that cause vessels to dilate. And as we said, vessel dilation causes pain and a bunch of other things to happen. Because your vessels are trying to help get more blood flow to your brain because you're not oxygenating at night because you're having obstruction of your airway. The other thing too is that people with sleep apnea often frequently awaken, but they might not even recognize it. And it's your body's protective way of trying to get you to awaken because you're not breathing and getting enough oxygen at night. So those frequent awakenings can actually lead to sleep deprivation. That's why a lot of people that have sleep apnea fall asleep very easily during really quiet activities during the day, or need to nap frequently, or just don't feel rested when they wake up. So what are some tips to deal with this? So talking with your primary care doctor about risks for sleep apnea, like am I at risk? And kind of screening for other symptoms that might suggest that sleep apnea is a diagnosis. And then considering a sleep specialist referral or sleep study. And then if someone is diagnosed with sleep apnea, again, I know this is very much easier said than done because I know a lot of people struggle with the CPAP or their treatment, but trying to be compliant with it. Weight loss can help with sleep apnea, and some people can reverse it or cure it. And then certainly avoidance of alcohol and certain medications that are sedating right before bed, because that does increase the risk of having those lack of oxygen events overnight. Migraine and exercise. So this can be sometimes challenging because we know in literature that lack of exercise can increase someone's risk for migraines if they're already predisposed to it. But a lot of patients also struggle that exercise can trigger headaches. So what is the positives of exercise and those that can tolerate it? We know it definitely can relieve stress, which obviously can also reduce your trigger load because stress itself can be a trigger for migraines. It helps us produce our natural feel-good chemicals, which are called endorphins. Those are thought to be protective against migraine to some degree. It also helps with decreasing muscle triggers by strengthening the muscles and stretching them. And if people do struggle with exercising, especially like with heavy exertion, whether it's running or lifting weights, sometimes we can pre-treat with an anti-inflammatory about 30 to 60 minutes before exercise. So like naproxen, which is Aleve over the counter, ibuprofen, which is Motrin, and then, certainly starting slowly, making sure you're well hydrated and warming up before you get into it. So, but even light activity like brisk walking or swimming or yoga, those things can all count and be helpful and protective against migraine. Diet. This is a big one. Sometimes very hard to regulate. So the thought is that a lot of these things, which a lot of them taste very, very good and are hard to limit, are noxious to the nervous system. And a lot of it is processed food. And we live, unfortunately, in a very processed world in terms of our food. So the ones I listed here are kind of what is known to be the most aggravating to some people's nervous system that can trigger a headache. So this is like flavor enhancers, hydrolyzed protein, whey protein, yeast extract. These things can really be hidden in your diet because you don't really know what foods have them. But if you turn over and look at a label to food, you'll see them listed. Artificial sweeteners, big one. We sometimes think that diet soda is a great thing because we're cutting the sugar, the calories, but some of those artificial sweeteners can really trigger migraines in some people. Alcohol can be a big one. Red wine has sulfites and tannins in them, and those are thought to be the triggers in red wine. Champagne's another one too. Caffeine, we'll talk about caffeine because sometimes we feel like it can help a headache, but overuse is not a good thing. Aged cheeses that has something called tyramine in it that can build up, and that's something that can certainly cause headaches. Chocolate and processed meats. Processed meats have something called nitrites in them, and that can be what we think triggers headaches in some individuals. All the good stuff. So it can be very difficult to get through the holidays sometimes with these things because they show up a lot. So caffeine, I alluded to this being a double-edged sword. So certainly we know, and patients will swear by it, and myself included sometimes, a cup of coffee or a pop can sometimes provide relief during a headache. And we think that's due to blood vessel constriction. However, when it wears off, there's rebound dilation of vessels. So sometimes people might have a rebound headache. The other thing is that it can contribute to dehydration, right? So caffeine dehydrates us. And kind of the rule of thumb that I learned in, I think, medical school is that for every 8 ounces of caffeine we ingest, we're supposed to have an additional 8 ounces of water or something hydrating to just break even. And I'm the first to admit I don't do that enough. The other interesting thing, too, is that caffeine is thought to inhibit magnesium absorption and being lost when we urinate. And that's an important thing because when we talk about supplements that may help some people with migraine, magnesium is a really important one that we think can be protective. So it's another reason why caffeine can be not a good thing sometimes. So again, I would be a hypocrite to say get rid of all caffeine because I love my coffee, but it's a matter of moderation, right? So guidelines suggest that you should limit caffeine intake to about 200 milligrams a day. That equates to about 2 cups of coffee. The other thing that's important too is keeping your caffeine intake consistent, and I think that's what's worked best for me. If I drink 2 cups of coffee in the morning and I might have one around 3 or 4 in the afternoon, that's just my threshold that I know I tolerate. If I'm having a really, rough day, didn't sleep well, and I'm going to increase it to 4 to 5 and I'm not going to hydrate well, I'm probably going to have too many triggers, lower that threshold and cause a migraine. So consistency can be helpful. And then if you are ingesting too much caffeine, we think that might be contributing, gradually cut back on it. Otherwise, you'll have a caffeine withdrawal headache, and those are not fun. And then if you can, trying to swap decaf for regular coffee, some people just crave the taste of coffee, for instance, or switching to caffeine-free soda would be helpful too. So stress and moods certainly are a big one with migraine. And thing that can be frustrating is, migraines can certainly be caused during stress, but they can also be caused after stress. And we think that's kind of from that letdown period that happens after our cortisol or stress hormones or adrenaline are kind of waning. So patients a lot of times will come to me and say, I get most of my headaches on the weekend, or sometimes people even struggle, like students in the summer when they're off for summer break. And so it's thought to be that sometimes after stress can trigger these as well. Mood disorder, especially anxiety and depression, definitely are coexistent with migraine quite a bit. And the thought is that is there some shared underlying chemical imbalance in serotonin amounts or other feel-good chemicals that are necessary? And the thing that can be frustrating is that these conditions can play into each other. So certainly having chronic headaches can be depressing and can cause anxiety. Like, gosh, will I be able to go to this concert? I don't know if I'm going to be able to tolerate the noise. And that can be anxiety provoking. And then the same thing is that, these conditions can cause migraines too. So they kind of fuel each other. And it's really important that we try to address mood and migraines so that hopefully both will get better. So what are things that you can do? Certainly trying to reduce your exposures to stressors as able. I know that's easier said than done. If we work a stressful job, trying to at least reducing your response to the stressors by taking some time out for yourself, and doing healthy coping techniques. Sometimes people benefit from therapy. Cognitive behavioral therapy can be helpful, or pain psychology also is a great idea to try to help people cope with what it's like to live with a chronic pain condition. It's not easy. And then certainly medications. There's some medications out there that are antidepressants that also have great data for treating migraine and tension type headaches. So sometimes we can find a medication that treats both nicely. All right, so we're going to transition into something called medication overuse headache. This is a very important topic, and I really want to make sure that the community understands this condition because it's not anybody's fault they get themselves into this, right? What do we do when we don't feel well? We try to reach for something that hopefully will allow us to function. But sometimes these things backfire. So, how do you define medication overuse headache? This is a headache occurring on more than half the month, so more than 15 days a month in a patient with a pre-existing headache disorder, right? So they might have maybe intermittent migraines, maybe 2, 3 times a month, or maybe a couple tension type headaches a month. And then they start taking these medications for these conditions, but things kind of start fueling each other. And we start having to take more rescue medications because we're having to take more medications, and they get into this cycle. And so this is regular overuse for more than 3 months of one of the drugs I listed below. And some of these are things that I prescribe. So I always have to be mindful of trying to keep my patients educated about not overusing these meds so they don't start backfiring. So we'll talk more about rescue therapies in a minute, but triptans like Imitrex or sumatriptan, and then something that's not used as often, but something called DHE, 10 or more days a month can kind of get you into that pattern. For most people, their insurances only cover 9 pills a month of like Imitrex, but if you maybe had a few good months and stockpiled your medications for months where you don't do as well and you're taking this, more than half the month, this could get you into trouble. More so what I see is the over-the-counter medications. It's the patients that sadly have struggled with headaches for years, and so they've been taking naproxen, twice a day, or they're taking ibuprofen 800 milligrams 3 times a day, and they're doing that most days of the month. Um, opiates actually do a lot of damage and really don't get to the root cause of, if alleviating a migraine. So you'll rarely see a neurologist or a headache specialist prescribing opiates. But if someone has them on hand for another condition and they use it for their headaches, again, that can cause overuse if you use it more than 10 days a month. Same thing with Excedrin, those combination pills that, they're so great at marketing, like, hey, this is Excedrin tension headache or migraine. They're really about the same thing, but again, they have caffeine in them, and they also have aspirin or acetaminophen, which is Tylenol. And again, those are things that are going to get you into trouble if you use them, 10 or more days a month for 3 months or more on end. The worst offender of this is butabitol. And butabitol is in medications that are prescribed that are Furoset and Furanol. This is really noxious to the nervous system, as much as people may swear by it, but less than 5 days a month is what is recommended in terms of use to try to avoid this. So very tough. I mean, sometimes in my practice, I'm kind of forced to prescribe certain things because of insurance, or someone might have certain medical conditions where they can't safely take other medications. So again, I have a few patients on this medication. However, it's a matter of the frequency. They really have to limit the amount that they use per month. So switching gears, we're going to talk a little bit about migraine and hormones, or the menstrual cycle. This is very common in a lot of female patients that are in my practice and in my colleagues. So the thought is that estrogen dips are what can trigger migraines in these patients. So estrogen typically tends to dip right before and during the onset of the menstrual period. This can happen in sometimes up to 60% of women. And so there's a lot of thought, like with women that struggle with premenstrual syndrome or PMS, and they get headache and nausea and some of these other symptoms. Is that just really a migraine? That's kind of a thought process in some literature. The nice thing is that, a lot of women come to me and say, gosh, I want to get pregnant, and I'm really worried about, not being able to take my medications because they're not safe in pregnancy. I'm just going to have a bunch of headaches. A lot of times it ends up being protective. Things might get a little rough the first trimester because those hormones are kind of all over the place and not consistent. But then second and third trimesters, most of my patients do great and feel awesome. So, and then the estrogen levels stay higher too during breastfeeding if a woman chooses to breastfeed. And so that also can be protective as well. And then in the perimenopausal state where estrogen levels are starting to dip, then we can sometimes see a resurgence in headaches as well. Some women do get better after menopause, not all, unfortunately, but if it was a significant trigger, sometimes they report, migraines are not as frequent. But again, it depends on their other triggers and where their threshold is in terms of whether things get better or not. So some tips, and again, this more so falls in line with probably discussing things with a primary care doctor or your OBGYN or your neurologist. Is continuous hormonal therapy appropriate? And that means, like, for women that are on a contraceptive pill, not taking the placebo pill to have a period. You just continuously take the parts that have the estrogen and progesterone in it to keep that estrogen level stable. Things that I will counsel my patients on is, medications that can be used for mini prevention just during the menstrual cycle itself. And there's good data that naproxen, which is a leave, can help, where you can take it, 3-4 days in a row, just the week of your menstrual cycle. So it's not going to get you in trouble for overuse. And some of the triptans that we prescribe also are long acting. So those ones can help during a period. And those medications can work really well for some people. Trying to minimize other triggers during the menstrual cycle can be, helpful. Again, trying to lower that trigger load so that we stay below the threshold. So staying hydrated, watching our diet, prioritizing sleep during that time if we're able to. And then for women that are in the perimenopausal or menopausal stage, is there a role for hormone replacement therapy? And that's something that would obviously be determined by probably an OBGYN specialist. I mentioned that migraine and other pain disorders can coexist very commonly together. So these can include fibromyalgia, irritable bowel syndrome, interstitial cystitis, and complex regional pain syndrome. It's thought that, in these patients, they have a hypersensitive brain. Those patients process brain differently, they process pain differently. They have a lower threshold to have something cause pain, things that shouldn't. And then in patients with something like irritable bowel syndrome, there's certainly a lot of data to suggest there's something called the gut-brain axis. And is there a disruption in this pathway? Is serotonin imbalanced in these patients? That's a thought for those that struggle with irritable bowel syndrome and or migraine. So again, I kind of mentioned, like, with dealing with stress and mood disorders, working with a pain psychologist can be helpful to try to help develop coping strategies for living with a chronic pain condition. Acupuncture, another nice option. Thing that can be a challenge with that is insurance doesn't typically cover that, but another nice option. And then, are there medications that can treat both migraine and the other pain condition? There are some that do have some good data. So definitely discussing that with whoever's treating your pain disorders. Migraine and nerve hypersensitivity is a really interesting concept, and this is really what's important to know for patients that start getting into a chronic headache pattern. What we know is that nerves on the periphery of the body become overly sensitive, and they cause pain and discomfort from something as little as a mild brush of the trigger point or to touch. And what peripheral sensitization is, that's the medical term, is that things that shouldn't hurt are painful. These nerves are just turned up, and they can cause a throbbing quality to the headache and the scalp nerves, and things very routine can aggravate them. And then this process leads to something called central sensitization, which is an amplification of pain signals in the brain. So think about like something that's just amplified, and so this is kind of the thought process behind patients that struggle with migraines or other headaches for years on end. Is they're in this cycle, and how do we break it? So for the peripheral sensitization part, when we're talking about the peripheral nerves on the scalp being overly sensitive, things like nerve blocks can be helpful. That's usually using lidocaine plus or minus a steroid, depending on the location, to kind of turn down this nerve signaling. And this is something that we do very commonly in our headache clinic at Honstein. That's often can also be done by pain specialists. And then the central sensitization part of things is often worked on by taking medications that try to bring that threshold up in the brain. Weather, that's a big one. We just had a really, really great fall, but then October, November, when we started having, I guess really more in November, typical Michigan weather, everyone's migraines went pretty frequent, at least in my practice, myself included. So what do we know about this, right? So some people say they have a barometer that lives inside their head. I agree with that, and I do too. We think what happens is changes in atmospheric pressure cause an imbalance in the pressure within the sinus cavities in the inner ear, which transmits pain. And then there's some thought that serotonin levels might be affected by weather changes, and we know serotonin's involved in migraine. So again, we can't control the weather, but monitoring for weather changes can be helpful. Avoiding triggers, if super cold weather. Wind hitting the face can trigger a migraine, or those peripheral nerves get really irritated, trying to avoid being outside if able. And then just kind of, again, trying to modify your other risks and keeping medications within reach. I will not leave the house during a rainy day without my migraine meds on me, just because you just never know what might hit. So something that can help kind of gather information for patients to try to say, well, what are my triggers? I don't know. Some people are, they've tried different things, and or maybe they're not sure, or they're dealing with a headache every single day. So like, well, I have a headache every day. How do I know what triggers my headache? Sometimes keeping a migraine journal can be helpful. The thing I try to stress to my patients is I don't want the headache journal to cause a headache. It shouldn't be difficult. I don't want it to be difficult. There's some apps out there that are really great. I listed these, Migraine Buddy and Migraine Monitor, that can help kind of guide you with things that might be helpful to track. Or I have some patients that will do it more pen and paper, or you can even go on websites like the National Headache Foundation and print one off. So you can track your symptoms, what medications you took, did they work? What are some of the triggers or things that might have led to the headache? And then trying to gather information to help whoever's helping to treat your headaches decide if there's anything else that they recommend.
So when treatment with lifestyle modifications are not enough, or certainly some migraines can be very disabling, where despite our best attempts at getting numbers down, we still have periodic headaches that can be very disabling in the moment. This is where we rely on rescue therapies. And a lot of patients, when they come to me, have tried a lot of the over-the-counter medications, which are typically best for like mild to moderate attacks. And then sometimes they just don't become enough. So for patients that feel like over-the-counter medications can work, there's certainly a role for those, and that can be acetaminophen, which is the brand name Tylenol, aspirin, ibuprofen, which is Motrin, naproxen, which is Aleve. And these are okay to use. I want to stress that certainly these have a role. It's just a matter of the frequency that they're used. When we get to a point where the headaches are so frequent that we're reaching for these medications more than half the month, then we run that risk for medication overuse headache, which can certainly start fueling the headache fire, so to speak, and continue the headache pattern where they become more frequent. And then again, just to kind of stress that just based on how these medications work and their potential to worsen the headaches at a lower use frequency, opioids and butabitol containing products like Fioricet and Fiorinol in most cases cause more harm than benefit. Occasionally, these are sometimes the only options that really do work for patients. And I do have a few of these patients that utilize these medications. We just have to do so in a very controlled environment, in the sense that they're not using them too frequently, that they have a good understanding that these medications really should only be used no more than 1 day per month, or I'm sorry, 1 day per week, in order to avoid that medication overuse component. And then sometimes patients need more than the over-the-counter meds, and that's probably the case for most migraine sufferers. And that's where we get into these migraine-specific treatments, which do require a prescription. The most common class that's typically used first line are called triptans. These are medications like sumatriptan, which is the brand Imitrex, or rizatriptan, which the brand name for that is Maxalt. There's a ton of other ones in that class as well. These are something that a lot of primary care physicians feel comfortable prescribing. There are some contraindications to using these medications because they do constrict blood vessels. So patients that have had a history of heart attack or have stents because they have cardiovascular disease, or they have peripheral vascular disease, or a history of stroke or warning sign for stroke, these are not safe. But luckily we have other options that have come out in the last few years as well. And that's the next line that says Gepants. That's a newer class of medication, which are safe in patients that have a history of coronary artery disease or stroke. And these medications, a lot of times people see on commercials, these are Nurtec, Ubrelvy, and Zavspret. And they block a protein that when it binds to its receptors on nerve endings, it stops kind of this cascade of events that's happening during a migraine. So they're very effective drugs as well. And then there's a couple other ones I listed too, just different classes. Again, Migranal and Trudhesa are not prescribed as often. They work in a different way to constrict blood vessels, because again, like we talked about a few slides ago, that's part of the reason why migraines cause pain, is vessels dilate. Again, this class would not be safe in patients with a history of heart issues or stroke. And then the last one, lasmiditan, or Rayvow is a medication that works kind of similar to triptans, but doesn't have that risk of vasoconstriction or clamping down on blood vessels. So these ones are safe in stroke patients and heart patients as well. So when would we consider preventative therapy in a patient? This is where they're maybe using medications too frequently, so they're running the risk of medication overuse headache. Maybe they have really disabling migraine attacks that despite taking a rescue med, it's lasting for a really long time. It's making them call off of school or work, or really making them dysfunctional for a few days a month, and that's just too many days to miss out on activities or work. The acute medication treatments are ineffective or contraindicated. That would maybe be a reason. Or they're just highly disabling, or patients just prefer that. I mean, it looks different for different patients in my practice when we consider this, but these are kind of the most common factors that we consider. So this slide is very busy and there's a lot on it, and I'm not going to go over each treatment in detail because that's kind of out of the scope of this talk. But I just want you to know how many available options there are to treat migraine out there. I think some patients come to me and they feel very hopeless, like they don't have any options. There's a lot of options. Some patients come to me have tried a lot of these in the past, some not, but there's some newer classes that certainly have shown to be very efficacious and less side effect burden as well. So just to kind of orient you, on the left half of the screen is the class of medications. So again, we use a lot of medications in medicine in general for different conditions or different indications. So again, when I say anti-epileptic drugs, doesn't mean that it's because I think these are seizures or that the medications are going to cause seizures, but that's what they were used for in general, but they have good headache data as well. A lot of the antidepressants, again, the thought is that in some people, is there a serotonin imbalance? And that's why those medications work for migraine as well. Some of the blood pressure medications also are used for migraine, as well as neurotoxins, which again is Botox. That's what onabotulinum toxin A is. And the caveat to that one is that medication is only approved for chronic migraines. So kind of going back a few slides, where patients are having at least 15 headache days a month and at least 8 of those are migraine. Botox is indication for chronic migraine only. So unfortunately, if you're having less frequent headaches than that, unfortunately, insurance won't cover it. But there's still a lot of other options. The newest class of medication that has come out since 2020 are these CGRP inhibitors, or calcitonin gene related peptide antibodies. And these are, again, I put the generics in, but maybe more commonly, they're known as their brand names, which people see commercials for: Aimovig, Emgality, Ajovy, Vyepti, for instance. These medications have been out for a few years, and they've been very effective because they block that protein that I mentioned that's part of the migraine pathway, and no other medication that we had before does that. So they really do work on blocking nerve signaling and downstream other things that happen in the brain that cause like dilation of blood vessels. So in my opinion, they're probably the most effective besides Botox injections in terms of how they work. And they're very well tolerated, pretty low side effect profile, and they don't have any drug-drug interactions, and they're safe in patients with a host of other comorbidities like heart issues or vascular issues. And then there's a couple other off-label medications I mentioned here. Memantine, some people might be familiar with, is also called Namenda. It's actually a medication we use to stabilize memory in dementia patients. So that's used off-label. And then cyproheptadine is a super old school medication, but a lot of times we might use it because it's pretty safe in pregnancy. Both of those are safe if we have to go the preventative route in pregnancy, because sadly, someone's headaches don't get better during pregnancy. And then I listed down here some other options for herbal and nutritional supplements, but I'm actually going to touch on that more on the next slide. So certainly there's been a lot of studies about nutraceuticals or supplements that can help with migraine. The 3 I have listed here have the best data. And magnesium is thought that people that respond to that may be deficient in magnesium in their cerebral spinal fluid. Again, we would never put someone through a spinal tap to determine that. But that's kind of the thought process. And magnesium is used in a lot of different nerve cell processes. So it's a very important cofactor. So it's used to help prevent attacks. The two forms of magnesium that actually have the best ability to cross something called the blood-brain barrier, so the medication is actually getting into the central nervous system, is the L-threonate form that has the best data for that. And then second would be glycinate. The reason why I usually prescribe glycinate or recommend that to my patients is it's more easily found over the counter and less expensive. But both of those are kind of the recommended forms. The recommended dose that was studied was 400 milligrams daily. I usually recommend taking it at night because there's a lot of studies that suggest that magnesium can help with sleep as well. And then if someone were to have some side effects like nausea or upset stomach, hopefully they'd sleep those off anyways. The main thing I see with magnesium is it is a natural laxative, so it definitely can cause loose stools or frank diarrhea. So just being mindful of that. The second one is riboflavin, which is vitamin B2. Again, used to prevent migraine attacks, make them less frequent and less severe when they do occur. Dose again is 400 milligrams. And the big thing that people will see if they're not aware of it is it makes your urine look like a neon yellow highlighter. And that is a normal side effect. Doesn't mean anything's wrong. You just kind of urinate out what your body's not using. Pretty well tolerated otherwise. And then CoQ10 or coenzyme Q10, that is another mineral or coenzyme that has been helpful as well. It's used a lot in the cardiovascular world for other things, but it also is really important in the nervous system. And that dose is recommended at 300 milligrams daily. Usually I don't see any side effects from this, but just in preparation of this talk, I did find that some people might notice nausea, loss of appetite, upset stomach, or diarrhea. And so it tends to be about 2 to 3 months on these in order for patients to find any benefit. So it's something you have to really kind of stick with. And that also goes back to like the preventative options too, just to kind of circle back to these medications. I know it's really hard to live with a daily headache or a frequent headache for months or years on end. But it takes time for these medications to kind of build up in your system and become stabilized in terms of them working. So for most of the oral medications, we recommend a trial of at least 8 to 10 weeks on a certain dose to know if it's going to work, which I realize is a long time. But just having that idea and kind of the realistic expectations that, taking a medication for a week or two, assuming no side effects, is probably not going to be enough time to know if it's going to be working. I would say of the treatments that work the quickest, sometimes you might get benefit within 2 to 4 weeks, are these newer medications, these CGRP antagonists, the ones that I mentioned, Aimovig, Emgality, Ajovy. I do see those working faster. And then Botox sometimes can take up to 3 rounds, which that's given 4 times a year, every 3 months to really see benefit. So you really have to kind of stick with a lot of these treatments to see improvement. So another option is something called neuromodulation devices. This is a non-medication option. A lot of these are dual approved for both rescue and prevention of migraine. And so I've listed these here. All of the ones on the slide have FDA approval. So they've actually been studied in clinical trials and shown to be beneficial. I'd say the main drawback to this option is cost and insurance coverage. So Cephally was the first one of these that was approved. It's kind of a little TENS unit, so meaning a cutaneous or skin stimulator, and it's stimulating branches of these scalp nerves that are part of a bigger nerve called the trigeminal nerve, to try to help kind of over time build up this tolerance where these nerves are not overstimulating. The thing about that's nice is you don't need a prescription for it. You can order this online and get it to your house, and you don't have to ever go through a doctor's office. The drawback is the cost. I think it's somewhere around $350 roughly, give or take. But they do have, at least from my knowledge, is they have a 90-day money-back guarantee. And I do have patients that have sent it back and do get their money back. So if it doesn't work, I would think 3 months of trying of that would be enough to know if it's going to be beneficial. The other one on the top here, Nerivio, this is something that you wear on your arm. It has dual approval for both prevention and rescue of migraines. It's a 45-minute treatment. And then the thought behind that is it's sending a little stimulus, like a little kind of poke to that bicep region. And you can dial up the stimulation over time. But what it's doing is, because you're feeling that, your brain is going to release natural feel-good chemicals called endorphins, and also increase serotonin and other things in your body to help prevent migraines or get rid of a migraine in the midst of one. And this one also is something that insurance will cover. They usually want to see trial and failure of some of the other things first, but that's something that can be discussed with your neurologist or whoever's treating your headaches. But that's a nice option too. The bottom left is something called GammaCore. It's a vagal nerve stimulator. It's something that you put on the neck, and it also is approved for use daily as a preventative or rescue in the midst of a migraine. And the thought is it's helping kind of activate your vagus nerve, which is something that when it is active, it kind of is a calming effect in terms of what it's doing in your body. It's that nerve that's activated that's the opposite of the fight or flight response. So that's a thought about why that works. The only time you can't use that one is if someone has underlying seizure disorder or epilepsy. And then the single pulse transcranial magnetic stimulation is something that gives a little impulse to the back of the head, again, trying to kind of change nerve and brain chemistry. And then this bottom one is Relivian. This one's the newest one that was recently approved in the last year, I believe. And similar to the Cephally device, you wear it, but it's targeting more than just these nerves. It's also getting to call the auriculotemporal nerves, the occipital nerves in the back. So it's kind of helping calm down multiple different nerves on the scalp, different than Cephally, which only targets the ones up here. So another great option for patients that are pregnant or really sensitive to medications. These are other options that can work. So briefly, I'm going to touch on a couple other topics. I know the majority of the talk today was on migraine. And again, I don't want to ignore other headache types, but just to kind of discern the difference between migraine. This is the common headache type that a lot of people have experienced at some point. Again, just to kind of briefly go over the difference between this and migraine. Is the duration. It can be shorter, like 30 minutes, up to a week long. Typically, patients have both sides of the head involved with this, okay? Again, don't have to have that criteria because you just need 3 of these 4. And the other thing that sets it apart from migraine is this is a headache that, yeah, it's annoying, but it's not aggravated by simple things like going up and down stairs or walking or bending forward. Migraine sufferers are going to tell you that in the midst of that, those things hurt. And then again, we're not seeing those other migraine features, the nausea, the vomiting, the light and sound sensitivity. And then again, you can further classify this by how frequent the headaches are. Episodic means you're having less than 15 of these a month. And then chronic is 15 or more, similar to how we define episodic and chronic migraine. So what are the triggers for tension headaches? A lot of them are the same as migraine: stress, diet, lack of eating, how we sleep or lack thereof. Another thing that can be very common with these headaches is mechanical or musculoskeletal triggers. How I'm sitting right now sometimes can cause headaches in people. So, kind of leaning forward, we tend to be more of in a flex posture because we're on our computers all day. So poor posture, muscle tension, if people grind their teeth at night or clench their jaw when they're stressed. Eye strain. We live in a very technological world. So sitting on a computer all day long, prolonged use of our phones can sometimes trigger these headaches. So what are tips to help during these? Physical therapy, acupuncture, massage. OMT stands for osteopathic manipulative therapy, which osteopathic physicians like myself and others are trained in medical school to use different manual techniques to help structural problems. So these can be ways to deal with headaches if they're mechanical in nature. Trigger point injections. That's something that people like myself do, or other pain specialists using lidocaine to do exactly what it sounds like, kind of break up trigger points in the neck or in the shoulder. Using little bits of lidocaine can be helpful. And then what can be done from the patient standpoint, trying to limit the use of electronics as much as able, or at least taking breaks throughout the day to give your eyes and your muscles a break. Blue wavelength blocker glasses or screens can be used. You can get glasses that block out that wavelength that tends to be noxious to the eyes and the brain, or even getting a drop down screen that can be put over the computer. That can also help for patients with migraine that have a lot of photosensitivity. And then if there's a TMJ component, or like clenching the jaw or grinding teeth at night, seeing a dentist for a bite guard potentially, or warm compresses to this area where the TMJ is located, or seeing a dedicated specialist to address this. Again, there are medications for this. Acutely, these patients do tend to use more of the over-the-counter medications because they do help. And that's okay, as long as we're, again, being mindful of less than 15 days a month for 3 or more months, so we don't get into that overuse cycle. And then there are some preventative treatments that have data, and that's what I've listed over here on the right. Those are things that would prescribe or be prescribed by a primary care physician or a headache specialist. So cluster headache, I will touch on this as well briefly. This is a very different type of headache. And the frequency is exactly not known. A lot of times patients just don't know what to see a doctor for, unfortunately. And so their estimation might be actually lower. But the last I saw, again, this is quite a bit of old data, but 2008 estimated about 150 per 100,000 people. I'd say it's probably along those lines more than 3. And then this tends to be more of a male predominant headache, not saying I don't have some female patients with this. And then the peak age is typically between 20 and 50 years old. And then big factors for this headache, again, not saying it's the reason why someone has it, but that can precipitate it, is smoking or passive smoke exposure. Head trauma also has some data to suggest patients might be at more risk. And again, genetics, meaning just how someone's DNA is wired. So this is a very different headache type as well, and it's a lot briefer than migraine. And again, when we talk about duration of headaches, it's without treatment on board or undertreated. So this is a very, very severe headache. Not to say migraine isn't, but it's just different in how it presents and how it feels. This is typically kind of in the orbital area or in the temple, and it is only one-sided. This is different than how migraine can be both sides. And it's pretty brief, lasting somewhere between 15 minutes to an hour and a half. And the other salient features of this headache is how much other symptoms come along with that. These are called autonomic symptoms, but this can be anything from eye redness or tearing, runny nose or congestion. Eyelid can actually look swollen. The pupil can be much bigger, or the eyelid can droop. And it's on the exact same side as the pain. And sometimes you can get these symptoms with migraine, but it's the kind of the severity of these symptoms. And in headache patients or cluster headache patients, if they're going to have eye, tearing, it's going to be running down their face, and their eye will be super drooped. It's pretty profound. So that's something that you can still see in migraine, kind of based on what's happening in the brain. But usually in migraine, it's going to be both sides and not to the same degree. The other thing that sets us apart from migraine is what the patient is doing during the headache. Patients are so disabled by this headache that they would rather cause pain elsewhere in order for them to not think about their headache. I've seen patients in my office pacing. I've seen grown men crying. I've seen people banging their heads on the wall. It's very disabling. So they're very restless and agitated versus the migraine patient. Yes, they're having severe pain too, but they're usually wanting to lay low. They're trying to relax. They want to be laying in bed. They want to have the shades pulled and no sound, and they're not moving. That's the difference between cluster and headache during cluster and a migraine patient. And then you can have sometimes multiple attacks in a day in cluster headache. Sometimes you can have up to an 8 in a day. And then these cluster periods can last sometimes for weeks or months on end. It's a very disabling condition by no means. And then again, there's episodic and chronic criteria for also depending on how often these cycles are happening. So usually people are coming to see a neurologist for this condition. And again, I use this slide also for my residents, so don't pay attention as much to the second part about level A use, but level A use just means like the best data we have. So again, some of the triptans are used, 100% oxygen. A lot of times we try to prescribe oxygen tanks for patients to have on hand because that will quell the headache sometimes within 5 minutes when they wear that during an attack. And then some of these nerve blocks that I mentioned for migraine also have great data for cluster headache. And then kind of going down to level B and level C, meaning not as great of data, but we still use it and some people benefit, all the way down to things when we say, kind of what ones do not show benefit. It's kind of listed toward the bottom. So in my opinion, there needs to be more research into cluster headache in terms of options because there seems to be less of that than in the migraine world. So a lot of information in this presentation. So hopefully all this screen time and all this information didn't cause you to have a headache during my talk. But let's summarize what we've learned. So we know that there's 3 common primary headache forms, meaning that we don't have an underlying brain tumor or something else going on that's causing a headache. And that's migraine, tension type, and cluster headaches. We learned that migraine is a complex kind of conglomeration of many things that likely cause it, including genetics and environmental factors. We also learned that migraine is more than just a headache. This is more than people just having pain in the head. You can throw up. You can have significant inability to just tolerate your own, your own environment during it. And then people can have dizziness or they can have stroke-like symptoms. So it's definitely more than just a headache. We learned that there are several triggers for migraine and other headaches too. Some of them are more modifiable than others. Obviously, we can't always predict when we're going to have a stressful day, but what we put in our body and how we sleep are things that we can work on. Then I know I harped on medication overuse, but it's because it's such a common thing that we neurologists experience. And so I just think the more education patients have about those medications, the better, so that we can better help serve them. And then we learned that there's many treatment options for migraine. This can include supplements, this can include prescription medication, as well as devices that are non-prescription based or don't put medication in the body. And then we talked about tension headaches briefly in the sense that they also have similar triggers to migraine. However, also looking at things like screen time and posture and other things that can cause those headaches. And then we touched on cluster headache as well as being a very disabling headache condition that's much different in how it presents compared to the other two headaches I talked about. And again, I know there's some stellar PCPs out there for sure that probably feel comfortable prescribing medications and dealing with this, and that is awesome. But a lot of patients end up in our clinics with the headache specialist. So these are my sources. I did want to kind of give a little bit of a talk about a book rather, that I think can be very helpful for some people that are really interested in diving into their triggers and trying to lower the trigger factors in their life and increase their threshold to have a migraine. And so a lot of that information is talked about in this book, Heal Your Headache by David Buchholz. I think I mentioned that earlier, that he is a neurologist at Johns Hopkins. It's a very helpful book for a lot of patients. And with that, I will turn it over to any questions.
Thank you, Dr. Sanders. We are going to now transition into our Q&A session. So the first question is a two-part question. Are migraines connected to autoimmune diseases or pregnancy loss?
Yeah, great question. I would like to say that, at least in my understanding of migraine, is that they are more correlated with each other rather than causal, at least in the autoimmune world. There's a lot of information coming out about that, and how much does migraine have an inflammatory part to it, right? So we talked about like the neurochemistry of migraine quite a bit earlier. So it is possible that there might be some underlying key between those two things. However, can't say for sure at this point, but do people with autoimmune conditions seem to have a higher risk or prevalence of migraine? At least in my practice, I would say yes. So I do think patients might be at higher risk, but I don't know if I can say for certain from a scientific standpoint why that is. And then in regards to pregnancy loss, I'm sorry that is something that anyone has to deal with as a woman or as a couple or family. It's very challenging. If there's some underlying hormonal imbalance, just kind of thinking in lines of that estrogen depletion, that can definitely cause migraines in perimenopausal women or women that have it at the time of their period. It's possible, I can imagine. But I don't know of any data that's ever come out saying that people that have migraines are at higher risk of pregnancy loss. I wouldn't say like those things cause each other necessarily, but could the underlying cause that's leading to infertility, if it's a hormonal imbalance, could that make it a higher risk for migraines based on what we know with estrogen involvement in migraine? I think so.
What do you recommend as next steps for a headache and or migraine that happens while sleeping?
Yeah, that's a great question. So one of the things, like I kind of alluded to, is what is happening during sleep. Is the patient just not getting enough sleep? Are they maybe dealing with another sleep disorder? I know we talked a little bit about obstructive sleep apnea as being a possibility, but certainly we also have to rule out other things. Like if someone's only having headaches that awaken them out of sleep, again, they may warrant some structural imaging, like an MRI of the brain, perhaps. Again, not to scare anybody, but when we are laying flat, our pressure inside our skull is higher in all of us. But if there's something in the brain that shouldn't be there, sometimes that can make headaches more prone when we're laying flat. Another thing I'm thinking offhand is if pain is more in the back of the head, could this be based on sleep position? Sometimes patients, if they have a lot of arthritis in the neck, or depending on like their pillow or their sleep position, sometimes that can trigger headaches as well. And then I know a lot of patients will ask me, well, what kind of pillow do you recommend? And I feel like that is such a very individualized question that, you can kind of look into a cervical pillow or something that gives more kind of support in the neck. You can kind of see those ones that kind of have like a little bit of a cushion that's like higher kind of towards the neck to kind of keep it upright a little bit. Sometimes that can be a little bit more comforting. But yeah, definitely see a doctor about that, and they can kind of screen to say, does imaging need to be done, or is this something from your neck, or do we warrant a sleep evaluation? Because there's definitely more than just obstructive sleep apnea from a sleep disorder standpoint that can affect sleep quality.
You mentioned genetics as a factor in migraines. What should we look for in our children, and is there any preventive care that could help them?
Yeah, great question. So we certainly don't know all the genes or many of the genes that could potentially be involved in why someone gets a migraine versus other people that don't. Offhand, I can think of one or two genes that are known to be associated with migraine, but they're also associated with a lot of other symptoms like imbalance and other very rare things. So I'd say probably 99.99% of patients don't fall in that category. But certainly we know these things run in families. And so it can be very difficult to discern, because it doesn't mean like if your child, if you as a child had headaches, that your child will also have headaches at the same age. It's like not very predictable. So at least in young children, and we didn't really talk about this as much because of the scope of the lecture, but some children can present with migraines as more abdominal symptoms. It's something called abdominal migraine. And these might be kids that feel nauseous or maybe do throw up and have a lot of stomach pain. And this can happen kind of cyclically or, kind of sporadically throughout the weeks or months. And sometimes, it's can be kind of missed, and it's not like any testing is going to show abnormalities. They might take them to the pediatrician to get ruled out for like a virus or something else going on in the gastrointestinal tract, and their workup will be normal. But something like that could be looked at, where kids, kind of are missing school or kind of have a belly ache and, have a hard time explaining what they're experiencing. And then later on in life, I'll have adults that come and see me, because I mostly treat adults, that felt like they had abdominal migraines as a kid and it was just not understood. So that's something to look at for kids. Again, I can't really give information like offhand about like the risk, like what percentage does a child have in terms of a risk of migraine, because parents do. But there's definitely a genetic component to most people's migraine, where someone in the family somewhere had migraines, whether it was an aunt or a grandparent, and maybe they were called sinus headaches or something like that, which again, we didn't really talk about too much, but there's really no such thing as a sinus headache. Most pain here, unless we have sinusitis, is actually probably a migraine.
Can you take a baby aspirin daily for headaches?
It's a good question. Ideally, for just the treatment of headache, I would say you run the risk of medication overuse headache. If you look at the data for that and what medications constitute risk for medication overuse headache, aspirin is in there. However, that also can be very challenging, because that talks about a huge population of patients that maybe have to be on a baby aspirin preventatively because they have stroke or heart attack risk factors. So if that's the case, then the risks outweigh the benefit. But if we're using it for the purpose of getting rid of a headache, I would say we'd need to be talking more about other preventative options on those slides that I talked about, either medications or supplements, that we don't have to rely on aspirin alone. But again, if someone needs to be on it from a heart standpoint or for stroke risk factor prevention, but again, it's different because you're using it for that. You're not like taking it just for the point of getting a headache, then that's okay.
What are the long-term effects of Fioricet use for headaches?
Yeah, great question. So the Fioricet contains 3 different medications in it. And the thing that tends to be the most problem causing for headaches is the butabital part. Butalbital is a barbiturate, which is a habit-forming medication over time. That's why it is a controlled substance, and it's something that has to be monitored. So not only can it be habit-forming in the sense of how that medication works on brain chemistry to make your brain and body kind of want more of it over time, we just know that it can fuel headache, probably based on that same mechanism. And it can do so with such a small amount. So the data that has come out over the past few years is saying that use more than 5 days per month can put someone at risk for medication overuse. So it's certainly at times risky to use that because it might actually do more harm than good, where, yeah, it might be great at getting rid of that particular headache, but is it increasing the headache numbers over time? And again, just, the concern of using a medication that can be habit forming over time can also be risky too. Like, patients have to be weaned off this medication very slowly to avoid withdrawal. If patients are using this daily or close to, this is not something that we can go cold turkey, because butalbital in some people, if they have a withdrawal from it, can actually cause seizures. So it's something that has to be done very carefully under the direction of a physician that's comfortable doing that.
Out of all of the lifestyle modifications that you mentioned, which do you think is the most important to reducing headaches?
Wow, good question. I guess this would be a personal opinion just based on what I see in my practice. I don't know if this would be based on data, because again, headache is so unique and it's patient dependent on what can cause it. I would say sleep has got to be probably the biggest one, at least that is somewhat controllable. And I think the amount of patients that I see in in the headache clinic here that have some sort of sleep issue, whether it's insomnia or, older patients sometimes have to get up a bunch of times to use the bathroom. So they're having sleep fragmentation. They might not be getting into that deep restorative sleep. I would say that a lot of times when my patients can focus on that one aspect alone, there can be improvement. And it might not be perfect. We might have to work on other things or add other medications or treatment modalities to their plan. But I think sleep is a really big one.
When would you recommend seeing a neurologist versus just being followed by a PCP?
Yeah, great question. So for patients that have episodic migraines, that maybe happen 2 or 3 times a month or less than that, and they, the primary care doctor can find a great rescue option like a triptan, assuming those are safe in that patient, they might be able to see the PCP alone and be well managed. And some primary care doctors do a great job of knowing the data for preventative options and trying 1 or 2 of those medications that were on that table that I showed for preventing headaches if they're just too frequent. So I would say that if your primary care doctor is not comfortable with prescribing preventative options, or maybe they've run through 1 or 2 and things are not getting better, that would be a reason to see a neurologist. If we're having any other symptoms, that are concerning, that don't really fit the bill of the typical migraine, like if someone is having an aura that's lasting very long, or they're having headaches that are consistently awakening them from sleep despite looking at sleep issues, or any red flags that the primary care doctor is not comfortable just calling part of migraine, that would maybe be an answer. And then sadly, unfortunately, the other thing that we see a lot is insurance companies kind of dictating. So some of these newer medications, from a prevention standpoint, a lot of the insurances require a neurologist evaluation to get it prescribed. And then Botox injections for prevention, a lot of times are done under the care of a neurologist or a headache specialist as well.
If I wanted to schedule an appointment with you or your team, how would I do that? Do I need a referral?
Great question. So we'd be happy to see you. But yes, we are a referral-based specialty clinic. So talking with your primary care doctor would be able to get the foot in the door, where they send a referral and then stating the referral for why they're sending you to us, to say, complicated, headache, or, can't get them under control, or whatever the question is regarding your headaches, and then just specify that it's for migraine, and we'd be happy to see you.
And just a few more, but would spending time with a nutritionist be of value?
And some patients maybe. The diet can be very tough because um, some are of the mindset that we have to get rid of all of the potential food triggers, which can be very difficult to do, and then kind of add them back slowly. And if that's what's kind of advised or thought, because we've looked at other risk factors in or triggers and kind of worked on those, that diet is really the only thing left to address, then it might, just because they can help with those elimination diets. They can be very difficult. I mean, some patients are good and they can know they eat X and they know they get a headache, so they can avoid it. But if there's a question about, how much is diet playing a role and they can't find anything specific on their own, then the patient might be best to do like an elimination diet through a nutritionist.
With the variable nature and monthly injectable medication, how can I tell if the headache has ended?
Yeah, good questions. I'm assuming when you say injection, that must be the monthly. That is something that if it's going to work, it's going to be pretty profound in patients that have a daily headache. And those medications do seem to have some ability to work on a medication overuse headache. So some of my patients come to me and I say, yeah, you're definitely in chronic migraine. I think there's a medication component to it as well. But let's start you on Aimovig or Ajovy. And usually what I see is those medications can work where patients are naturally using less of the over-the-counter medications or whatever got them into the overuse pattern because those medications are working. So they'll start seeing breakups in their headache. It might not be perfect the first month or two, but they're noticing maybe some headache-free hours or headache-free days, and that would be a win. Majority of patients in the trial that got those medications approved by month 2 had at least 50% less headaches or more. And I would say that's pretty consistent with what I see in my practice, where patients are coming back to me at that 3-month visit, and let's say they had an everyday headache before, and maybe now they're only having 3 or 4 a month. Some might not respond that quickly and have that more robust of a response, but yeah, there's usually a night and day difference within a couple of 3 months that is meaningful, and sometimes that can just improve over the coming months.
And finally, how can I get past the mental stage of being tired of fighting the headache and restart my life?
Yeah, fatigue's a big one, right? You're constantly in this cycle of having headaches, and then we know there's a postrum to migraine that can last sometimes a day or two, where patients just feel exhausted and drained, and being in pain is draining. So that's a great question. I think trying to find the right treatment plan is going to help that. I think you have to kind of learn to say no at times too. I think a lot of times, and again, people are rightfully so frustrated by having to cancel plans and miss work and things. But until like the right treatment plan is in place, trying to limit things that overextend yourself, because you have to kind of give yourself grace while your brain is healing from this. So taking time out for yourself, finding ways to help reduce stress, journaling, talking with the pain psychologist about how to deal with and cope with living in chronic pain. And then again, hopefully when the right treatment plan is in place, some of that fatigue also will lift because we're treating the migraines adequately. If you're constantly in the cycle of going in and out of migraine, your brain is tired. So hopefully those suggestions will help.
Well, thank you again, Dr. Sanders, for your presentation and insightful Q&A. To all our participants, thank you for joining us, and we hope you have a wonderful rest of your day.
Thank you for joining. It was my pleasure to give this talk. Thank you so much.